welcome to my presentation for PMSC13002. During this presentation, I'll be discussing an asthma case that I went to on placement. Early in the morning after a long night shift, we were called to an 18-year-old female with ineffective breathing. We were told that CPR had been started, but when we got to scene, our patient was conscious and the boyfriend was no longer doing any sort of CPR. He stated that when the patient woke up, she told him that he was feeling short of breath, and he called the ambulance for her. On arrival, she was lying in bed. She was obviously distressed and short of breath, but able to talk in short phrases. Initially said that she felt nauseous, but this was denied later. The crew on scene was my Bravo crew, plus myself, and because it was a one Bravo case and CPR had been started, the CCP team were deployed and they arrived shortly after us. As my second officer started to get our initial set of vitals, I started to ask the patient a basic history. We found that she has a history of asthma with 2 ICU admissions in the last 12 months and has currently had a chest infection for 2 weeks. She has an allergic reaction to Bactrim and is currently on the Symbicort, Rappahala, and Ventolin for her asthma. After asking this series of questions, I started to do my respiratory assessment. As you can see on the screen now, this is the initial return of the patient's vital signs. We had a GCS of 15, afebrile, slightly tachy, but otherwise normotensive patient. Of note is the respiratory assessment results. Her resp rate came back at 38 with a laboured rhythm using accessory muscles to breathe. Particularly of note is the auscultation, which returned diminished to nil lung sounds bilaterally. Patient was still able to talk in short phrases and there was no sign of cyanosis yet. We came to the conclusion that the diagnosis for this patient was a moderate to severe asthma based on her history and the signs and symptoms that she was presenting with. Potential differentials in other asthma cases can include foreign body, COPD, APO, and bronchitis, which were all ruled out based on the patient's age, her history, and further severe infections by the fact that she was afebrile. As shown here, 11.2% of Australians have asthma. It's more common in males until the age of 14, after which it's more common in females. It's twice as prevalent in Indigenous people and is more prevalent in low socioeconomic areas and inner regional areas when compared to cities or countries. In 2014-2015, there were 39,500 hospitalizations, and the latest statistic in 2017 said that there were 441 deaths as a direct relation to asthma complications. Asthma is defined as a chronic inflammatory disorder of the lower airways, resulting in intermittent or persistent airway obstruction. Asthma can be triggered by a number of things, including smoke, dust, illness, and anxiety. In this patient in particular, I would suspect that the trigger for her asthma would be this ongoing chest infection or potentially the cold air of the morning, as it was quite cool. Exposures to triggers causes the IgM mast cells to trigger the release of chemical mediators. And these chemical mediators stimulate bronchospasm, swelling of the airways, and excess mucus production, all of which lead to the signs and symptoms of asthma. Once my mentor and I were happy that we were treating down the path of asthma, we followed the ASPA CPG and applied salbutamol 5 milligrams and ibuprofen bromide 500 micrograms nebulized on 8 litres of oxygen to our patient. We then attempted IV access, myself once and my mentor once, and we both were unable to get an IV in place. At that time, our CCP backup arrived and they were able to gain access to the patient. We applied more salbutamol nebulized throughout our management until handover to hospital. And the CCP himself applied IV salbutamol, magnesium sulfate, and hydrocortisone. We extricated using an office chair at the patient's home, and gave another dose of ibuprofen bromide post-extrication. The transport to hospital was otherwise uneventful, and our patient saw a generalised upwards turn. As the patient care officer on this job, it was my role to continuously monitor the patient, as well as continuously monitor the nebulizer that we had on, and administer salbutamol as it ran out, and then administered 2 doses of ibuprofen bromide, 20 minutes apart as directed by the DTP. Our CCP was able to assist with his own arsenal. He was able to supplement the nebulized salbutamol with his own IV salbutamol. And we were set up a spring fusor to administer magnesium sulfate, which assists with the bronchodilation. And then we also gave 200 milligrams of hydrocortisone, which instead of treating the symptoms, goes back to try and treat and stop that IgM mast cell release and the release of the cell chemical mediators that it triggers. And you might be wondering through all this, if you are familiar with the asthma CPG, why didn't we administer adrenaline to this patient? Our patient responded really well initially to the nebulized medication. Adrenaline was, of course, considered, but ultimately we decided that we weren't going to administer to this patient because she responded so well to the medications that we had given her. And if you have a look at the adrenaline DTP, you'll actually see that the patient wasn't actually indicated for adrenaline, as she was able to speak in phrases. She wasn't hemodynamically compromised, and she didn't have any altered levels of consciousness. So this slide here just shows the general upwards trend of our patient's condition. The rest rate came down from an initial 38 to 28. The rhythm went from laboured to a regular rhythm. The effort went from using accessory muscles to just being an increased rate work of effort. We came back with from diminished sounds to having an inspiratory wheeze with clear sounds on expiration. And our patient on arrival to hospital was able to speak in full sentences. Of note there is the patient's pulse rate spiked to a high of 155. This is due to the side effect from salbutamol, which causes tachycardias and tachyarrhythmias. There were no great difficulties with this case. Our patient was very easy to work with, was very receptive of the treatment. We did have difficulties moving around her in such a small space, especially with 5 people on scene, and the extrication was quite tight through some narrow hallways and down a set of stairs. But apart from that, there were no other real difficulties on scene. This is one of the first real higher acuity jobs that I'd been able to start and finish patient care on, apart from the input of the CCP. This was primarily my patient. I started and finished with the handover at the hospital with the CCP's assistance. I found at this stage of my placement, I had excellent recall on all the relevant CPGs and DTPs and was able to apply them. My mentor was very happy with my patient communication and my management plan. Having the CCP on scene allowed us for a slightly greater scope of practice, and we were able to utilise the magnesium sulfate and the hydrocortisone for our patient. A consideration with that is, having been on a rural placement, I know the availabilities of CCPs in those areas is not as great as it is in cities or regional centres. And knowing this, I would be prepared to consult for the use of magnesium sulfate and hydrocortisone as we carry it in our kits, if I believed the patient was believed if it was necessary for the patient. Another consideration for a job like this is that it was a big team with 2 paramedics, myself, the CCP, and the CCP the intern supervisor. It meant there were a lot of hands available for jobs such as preparing drugs, but it also meant that there was a greater opportunity for mismanagement and miscommunication had we not been able to work together as a team. The prognosis for this patient is good, with some good control, regular medications, and advice from the doctor. This patient should be able to live with a good quality of life, with the occasional exacerbations of her condition. There are some long-term consequences in terms of irreversible airway narrowing if she is non-compliant with her medications, but with a suitable treatment plan that suits her and education from her doctor, she should be able to continue on having a good quality of life with the asthma interfering as little as possible. Thank you for listening to my presentation. I hope you enjoyed it. I hope you took something away for it. And I'm really looking forward to my next placement and moving on in my career as a future paramedic. Thank you.